Hi everyone, this is Neil here, also known as the Wax Whisperer. Thank you for tuning in to my latest video. It is quite an extreme case of earwax impaction, more so in the patient's left ear. I actually performed the procedure in the left ear first whilst the patient was here, but in this video I'm first of all going to show you the removal in the right ear, and then after that you'll see the left ear, which is a lot more complex, impacted, and it took a lot longer. So here we have the patient's right ear. You can see she's got very dry ear canals, very dry skin. The wax is also quite dry here. There's a lot of keratin. You can see there on the right hand side on the anterior lateral canal wall. So the front part of the ear canal, near the entrance, you've got a thick layer of skin attached to the ear canal, but also attached to the earwax, and we've just got a lot of dead skin here at the base. The earwax is very dry and crumbly, almost like a short crisp biscuit. Just use some suction to begin with, and I'm just going in with some forceps. You can see the forceps had been used before. Don't worry, that was not with another patient. As I said, I actually performed the procedure in the left ear first, where I also used the forceps. So I'm just trying to get a grip there. The entrance is quite narrow. When you've got a lot of hard, dry skin and wax, you do get a light reflection off the torch, off the eye clear scope, hence why you saw there at the beginning. You were getting a bit of a reflection. You can see the tail of dead skin and some wax, and just prizing that out of the ear. You can see, just see how dry and crumbly that wax is there. Again, just using the forceps, just gripping onto it. The patient had previously visited me a couple of years ago, and we had a similar scenario then, if I remember correctly, and I did advise them to attend a lot more regularly, but unfortunately they did leave it a bit too long. Not so much the right side, but you will see the left side is extremely severe. Quite a painstaking procedure, and also when the patient attended, she was reporting severe otalgia. So otalgia is an earache in the left ear, and whenever a patient contacts us and saying they've got an earache, we know that's going to be a difficult procedure, not only due to the fact that we know there's going to be a severe impaction there, but when they're already suffering from earache, and I'm doing the procedure, well, putting instruments in the ears is not really going to always alleviate the pain initially, because the instruments, obviously, no matter how careful and delicate we are, it may add to that pain threshold. But as we remove the layers of wax, that pain that they're experiencing will be slowly alleviated. So you're just using some forceps again. We've just got some dead keratin on the anterior lateral canal wall, just trying to get a grip using some forceps, but it's a bit difficult because of the angle at the entrance is a bit narrow, so I wasn't able to get the forceps in the correct angle to prise that dead skin. So I'm just using a fine end gauge. Fine end gauge attached to the standard Zollner suction probe is very efficient for peeling dead keratin off the canal wall. You can just see how dry her ear canal is. So she has got a bit of otitis externa. She doesn't suffer from the typical symptoms of otitis externa, which can be some itchiness and irritation. She did advise that she was getting water in the ear, so I have re-instructed her. Water in the ear is really bad. I don't necessarily have any issues with my ear, but I do avoid water entering the ear. And there's bacteria in the water that can cause infection, dryness, itchiness. So please do avoid that at home. Some tips to avoid watering going in your ears: you can get some custom swim molds or tips whereby the audiologist takes a cast, so an oral impression of your ear, and then they can manufacture a silicone hypoallergenic mold which you place in your ear, which prevents water entering. There are also foam earplugs or silicone foam swim plugs you can get over the counter. The most simplest way is a ball of cotton wool. Just apply some Vaseline around the edge, insert it just at the entrance. You don't want to push the cotton wool ball too far in, because if you have got wax, you are going to further impact that, and obviously you do have to retrieve that cotton wool ball. See some dry skin, very medial, that was near the eardrum, on the bony part of the ear canal. Still got some, I mean, in terms of her symptoms, she's able to hear, but obviously I do want to get this skin out. I don't want it to get infected, and because this patient is a chronic sufferer from earwax and dead skin. Sorry about that blackout moment where I didn't edit. Again, fine end tip. Fine end's also very good with dead skin because if you use the standard size Zollner suction probe, you don't have that precision when you're working along the canal wall. Also, the standard Zollner suction probe can cause clarinetting of dead skin. So clarinetting is when the skin gets stuck at the tip of the suction probe and violently flaps, and that emits a very high frequency squeal, which is not only deafening for the patient but also for the clinical ear care specialist performing the procedure. Just a bit of skin there, so I am going to get that out. I think I'm using some forceps just to get that out, but more so because it's not. I think with that flap of skin, if it is a windy day or the patient's eating or chewing and the ear canal's moving, they sometimes can feel a flap of skin like that moving around in the ear, which can be a bit irritating. There's a tympanic membrane, the eardrum, that looks nice and healthy. We can see the hammer bone, which we call the malleus. You've got the light reflexes, which is to the front, so the anterior, and just slightly below inferior. So in terms of a compass, you're looking at southeast. There's always a light reflex there. Someone's got a very healthy eardrum. It's just a reflection of the torch, in our case the eye clear scope, reflecting of the pars tensor, which is the thicker part of the eardrum. That's in the right location. So here we are. Here's the left side. And straight away, remember I did the left ear first when the patient arrived. You know that wax is really hard just by the reflection I got from the light source from the eye clear scope. And you can just see how hard that is. If I had live audio, you would hear a ping. It is as hard as a rock. It is rock solid. And I'm just trying to actually get into it, and then sometimes with hard wax, if you can get the ear hook into the big mass of wax, you can extract it in one big piece, but this is just way too hard. Again, it's really difficult just to penetrate. If I was to hurl this piece of dry hard wax against my clinic window, it will no doubt crack the window. Again, you can see I'm having problems even penetrating, even getting into the wax. It's so hard, the ear hook is just gliding off the surface. Just using this Zollner suction probe just to suction some of the remnants. And what I'm trying to do is see if I can lift this from the bottom or from the top, from the edge, just trying to loosen it from the canal wall, but it's just too hard. And this is the ear, the patient is reporting earache, ontalgia. Again, just trying to get the ear hook in between the wax plug, and so it's not only wax, but it's dead skin, and the canal wall. Just managed to find a bit of a weak spot there in the plug of wax and dead keratin. I'm just trying to lever this forward, but it's quite a tedious procedure. At this stage, we're not able to use any other instruments. For example, a forceps, crocodile forceps, you need something to grip onto, and this is a flat surface. The distal end of the forceps, so the pointed bit, is just going to poke into the wax. It's not going to grip onto anything. It's nothing for me to grip onto at the moment, but I will be using the forceps later on in the procedure to somewhat good effect. Just on the posterior canal wall near the entrance, just trying to see if I can get in there, but there's no entry, so again I'm just going anteriorly. When you've got an impaction like this, which is so severe, you do find the ear canal somewhat inflames and swells, and it engulfs the wax, which makes it even more difficult because you've got this canal almost trapping it, almost like a spider's web. It's got that wax and dead skin plug in its grasp, and it doesn't want to let go. And actually, I think that's the main cause for the patient's pain. This impaction is so severe, it's really compressed against the canal wall. Again, just going superiorly. I don't know if you can tell just by watching the video how much pressure I'm trying to apply, and it's always very difficult with these cases because when you've got a big plug of dead wax and skin like this, which is rock solid, as soon as you insert an instrument, you're putting pressure against that. And if this plug is extending all the way to the eardrum, you are in some way pushing the wax against the drum, which is causing more pain. Just put some sodium bicarbonate drops in here, but deep down I kind of felt that it wasn't going to do much. Now you look at it once I've drained it, you think, oh wow, that's gone soft and wet, and it's going to make the procedure easier. But this is just a thin film of wax and dead skin, just at the entrance that's got a bit soft and wax, you'll see it's not really penetrated. And if I was to continue using drops, I would have to use the drops possibly about, say, 20 times, because we'll just be doing it in thin 1mm layers at a time. So again, that's as much benefit the drops has given to me in this occasion. It's not really done much, no, not really much further deeper in the ear. So again, it's just one of these procedures you just have to be patient, tedious. I know some viewers just feel as though, well, why don't you just hook it out in one quick, easy go? It's not as easy as that. I don't want the patient sat here for 10-20 minutes whilst I'm struggling to remove the wax. I'm sure the patient doesn't want that. And obviously the patient is awake, there's no anaesthetic. Whenever people feel like making comments like that, I simply ask, imagine if this is your ear and you're in severe pain even before attending the appointment. And I don't really think you want your clinical ear care specialist going in gung-ho, all guns blazing, just adding to your pain. During this procedure, I was forever talking to the patient, making sure they're okay. More so in the left ear, the right side wasn't an issue. Just to make sure she's not experiencing any additional otalgia, I'm not causing any distress to her. And she was really good. She kind of was slightly apologetic because she knew she should have come a lot sooner. But we live and we learn, and the patient is fully aware that she needs to attend a lot more regularly. Provided her with some general ear care advice, such as using ear drops regularly. Using drops as a preventative measure is the way forward. So I did explain to her, once I've cleared all the wax, I do want her to use, I think in her case it was ear oil, so olive oil, earwax spray, and I think I asked her to use it fortnightly. And the key is you don't do per ear the same night, and that'll become clearer as to why I'm advising against that. So always use the drops before you go to bed. Obviously you don't want to be using it during the day. Tilt the ear that you're putting the drops in towards the ceiling, so you can lay on a bed and horizontally make sure that ear that you're putting it in is facing the ceiling, and be very general and liberal with the drops. Most manufacturers, on the instructions, it's 1 or 2 squirts. If you're going to use ear oil, olive oil spray, then I would recommend just filling up your ear completely. 6, 7, 8 squirts is how many drops you need. The moment you feel a bit of coldness in your ear, that's a good omen, because that means the drops have settled onto your eardrum. Let it rest for 5 minutes, and after 5 minutes you then turn your head over the opposite way, so that ear is now facing the ground, and you want to rinse that drops out. Idea of rinsing it is, if you don't rinse your ear, a lot of patients tell me they fill up their ear, they put a piece of cotton wool which is just going to absorb the drops anyway, and they sleep on that side, but all you're doing, you're softening that wax, and once that wax is soft, it's just going to run further and deeper into your ear canal and settle onto the eardrum. So you want to rinse your ear. So you can't rinse your ear using water. I mentioned that when I was performing the procedure in the patient's right ear, you need to avoid water in the ear like the plague. It's really bad for you. It can lead to infection. So in a way, in essence, you're using drops, earwax drops, to rinse your ear as a substitute for water. And when you drain your ear, so obviously when you've got your ear facing the ground, put a tissue underneath so that it collects all that drops. And the idea is any small pieces of wax or dead skin, before it builds up, you're softening it as you're soaking your ear, and then when you tilt your head the opposite way, these soft pieces of wax that you soften will hopefully drizzle out your ear. Also, olive oil can help lubricate the ear canal wall, preventing that thin layer of skin from drying and cracking. It can also help with the natural migration of wax. So if you've got dry skin or dry wax, the oil will help with that conveyor belt motion. So if you've been watching a lot of my videos, you should be aware that earwax, and most people, probably 90–95% of people, naturally expels itself out of the ear. And the reason for that the skin that coats the ear canal, as it sheds, it naturally migrates. It's got a unique property. If it wasn't able to do that, then everyone's ears would be constantly full of dead skin, which you would have to see a professional to remove. And as that skin migrates, it takes with it the wax. So if you've got dry skin or dry wax, you're going to get friction. And olive oil is slightly acidic. and earwax is also slightly acidic, so you're very unlikely to get an adverse reaction if you use olive oil earwax drops. And we do recommend using the stuff over the counter. It's chemically treated for safe use in the ear, as opposed to the olive oil you use at home. So definitely get them from the chemist or the pharmacy. And I'm just using a Jobson horn, and just trying to get in behind the wax. And if you, sorry, I was just explaining general ear care there, but you were watching. I'm just going to get this out in layers. It's almost like a hammer and a chisel effect. We're going to break this wax into small pieces. You can just see it just by how much, you can tell how much pressure I'm trying to use the Jobson horn with to get into the wax to prise it out. Just want to go back to the ear care, because I did say I'll explain why you don't do both ears the same night. So just say you were soaking the right ear and then draining the right ear. If you then put drops in your left ear and then after 5 minutes drain your left ear, you run the risk of some of the oil in the right ear seeping back into the ear, and therefore the wax going back into the ear and potentially settling onto the tympanic membrane, the eardrum. So 1 ear per night. I generally recommend for most people do that monthly. You don't want to excessively use any drops in your ears, especially some of the drops like sodium bicarbonate drops or hydrogen peroxide drops, because they are water-based, so people are a bit more prone to getting an adverse reaction with them. And also they are alkaline, so people can get as I said to you before, the ear is slightly acidic in nature, so the alkaline nature of those types of drops can cause a bit of sensitivity. So just once a month. I wouldn't recommend any more unless you've been instructed by your ear care specialist. So just gone in with the ear, you can see that thick layer of keratin. We have got this reflection as well from the eye clear scope, and that's, as I said, it's just the hard wax and dead skin. It's just the light shining against it and reflecting back. Nothing much we can do. It's not really affecting me. Now, here I've gone in with the forceps because I've now created something for me to grip onto. When you've got a flat surface like we did before, well, I couldn't use the forceps. There's nothing for me to grip onto, but I managed slowly to retract and elevate this thick layer of skin and wax off the posterior canal wall, and there's now something for the forceps to glide into and then grip. And you can see I've just got the right hand jaw of the forceps near the canal wall, trying to glide in, which allows me to get a good grip, and I'm just pulling a lot of this wax and dead keratin out. You can tell we're quite lateral as well, so when we've got cilia hair like this, it means that we are near the entrance still, in the outer third at least. So we're probably about 1 centimetre into this impaction, and this impaction was right from the entrance all the way to the tympanic membrane, and the average ear canal, give or take, is about 3 centimetres. If you're following me on Facebook, you may have seen over the last couple of days I've started to weigh earwax, and it's a shame that I didn't have these really precise scales for this particular procedure, because it would be interesting to see how much all of the earwax and dead skin that I extracted from both ears actually weighed. So I've only used it with a couple of clients. One of the clients, it was 60 milligrams, so 0.06 grams, and the other patient was almost half a gram, so it was 0.45 grams, which is 450 milligrams. I suspect, based on that particular client, that a really severe impaction could be up to 2 or 3 grams. So stay tuned. I have got loads of videos that I am backdating and trying to upload, but at the same time, as I perform newer procedures and I begin to weigh the wax, I will kind of upload them as well. So, and it'll be interesting to see in about a year's time who holds the record. I'll have almost like a little leaderboard, and we can see who has the crown of the biggest earwax removed in terms of weight, at least. So that'll be interesting. Again, you can just see how dry this ear canal is. You've got layers of thick keratin, and then in the center you've got the wax. Again, I'm just trying to lift this, and by lifting it, it's creating a gap at the base of the ear canal, which allows me to use some forceps, and I can just glide this in, and you can see I've got something to grip onto now. It's not a flat surface. Again, you do have to be really careful. The inner 2/3 of the ear canals, it's a thin layer of skin directly on bone. It's very delicate, very sensitive. And even with the forceps, you can see how much I'm pulling trying to get this out. There we go. So the majority of that is actually dead keratin. We've still got more. If this patient had been using Earol, so Earol is a brand of olive oil earwax drops. I'm not sure if it's available in America, but it's very popular in the UK, and it comes with a spray applicator. We'll be selling that on our online shop shortly. So I run two businesses, the Hair Clinic and also Clearwax, and it will be on the Clearwax website in the next month or so. The web link for that is www.clearwax.co.uk. If the patient had been using the olive oil spray regularly prior to attending, I can't guarantee that she wouldn't have any wax, but I could guarantee that this wax would be a lot softer and less adhered to the canal wall, making the extraction easier. Again, just like earlier, I'm just trying to lift this upwards, and I believe I will then go back in with the forceps. You can see how thick that layer of skin is there. It's stuck almost like super glue, double-sided tape against the canal wall. And I do have to be really careful here. I don't want to get the sharp pointed bit of the forceps. I don't want to make contact with the patient's canal wall. As you remember, she was experiencing a lot of pain even prior to attending in this ear. Let's just peel that big chunk of wax and dead keratin. Once I peel, I'm just wriggling it around in concentric circles, bringing it forwards. So it almost came out in a big piece, and some got left behind at the entrance. So this wax, you can see it's a lot darker in colour. It's further into the ear canal, so it's oxidised, hence why it's a darker colour. There's still a fair bit in there, so you can see probably I've removed a lot already. But all the medial wax deep in the ear, we've brought it forwards now. It's hard to get a grip on this, it was sliding away. A bit slippery customer, this piece of wax, but I was victorious in the end. So I've gone in with so it's a bit tricky there with the forceps, you're losing grip, so I decided to go back in with the Zollner suction probe and peel this slowly. So although the beginning of the procedure was quite difficult, quite often with earwax removal, it's almost like Jenga, you pull one block and everything topples over, and it's the same with when you perform the procedure in the ear. There comes a stage where you remove one piece of wax, which is almost like the fulcrum, the centerpiece, that's holding all this impaction together. And once you've removed that, the procedure just becomes a lot less complex. So just gone in with the Zollner suction probe, the fine end attached, and just peeling this thick skin, but I think I'm going to go in with the forceps because it is quite adhered. Again, with skin, it's not always a clinical need to remove, and when you do remove skin, you can get blistering of the ear canal. Imagine some dry skin on your finger on a cold winter's day, and you're peeling that off. It can sting you. This is the ear, so the ear is a lot more sensitive than your fingertips. So you have to evaluate as a specialist whether you need to remove it. And because this impaction was so severe, I just wanted to get as much skin out as I could. So just going in with a fine end again. You can see the canal wall, the flesh just also moving alongside the keratin as I'm peeling this off. There we are. And again, sometimes you hear some comments or read some comments, why did you leave some skin? Well, you can see how much pressure was there. Again, I always kind of just request people, before you make comments, just imagine this is your ear. You wouldn't really want to go back to someone causing you pain, would you? And you're awake, there's no local anaesthetic, no general anaesthetic, so do appreciate that fact. how would you want someone performing the procedure in your ear? Do you want it to be slightly longer but comfortable, or quick, probably unsuccessful, causing pain, bruising and extreme discomfort? Well, I know what I'll pick for sure. There we are, last bit of skin. I think I'm going to use the forceps just to get this last bit off, because again it's not going to affect the patient's hearing, but it can flap around as large flaps, just being really delicate. There we are, Eureka. I think I'm just going to just mop up a bit now, just get some of these loose fragments of keratin wax off the canal wall. And there we are, nice healthy translucent tympanic membrane. So this is the Hall of Earwax. I've got 4 screenshots. You can see it's a lot of wax. I really do wish that I had these precision scales. I would have weighed all this. It'd be really fascinating. So this is quite up there with kind of the biggest extraction you would expect to remove. But I hope you enjoyed that video, guys. If you're watching on YouTube for the first time, please do subscribe. Select the bell icon so you'll get notified as and when I upload new videos. Similarly on Facebook, please do like, follow the page, feel free to leave a comment. And I hope you enjoy the rest of your Sunday, guys. Take care, bye.